schedule. I was supposed to be at a conference in Atlanta, Georgia, and totally forgot that the conference got canceled. So this past Thursday, I saw my Friday schedule was empty, and I decided to take off today because I felt like I needed a day off. I haven't had a day off since Christmas because we were working straight through. So it was kind of nice to have a day just outside in the garden, weeding it, getting a little sun. So hopefully you all are having a little time off as well. It was actually nice to have a slow day. So hopefully I'll have more as the future comes around. So we're just waiting for both technologies to pop up here. So if you're as you're coming on, this is a Q&A session. If you have questions, save them. You can put them out there. We have a list that people have already submitted that we'll be going through. And if you have additional questions, we can answer those as time permits. There'll also be some articles we'll be posting related to the questions that will be available on social media. Looking for those and some references as well to Facebook and other things we're posting out there. So just kind of stay abreast of all those things. We'll keep you in the loop with everything we're doing. And as soon as everything's going, I get the nod, we'll go on and start answering questions.
Could you ask Facebook if people can hear you?
Can people on Facebook hear?
Is the audio okay?
Is the audio on Facebook okay?
It's going to be a delay.
Okay.
Just remember.
Okay. And the questions, my director of Internet Affairs, Rebecca, will be asking the questions. So that's the voice you'll be hearing in the background. Everybody needs a title, so we created one. Can Facebook first?
I think we got some thumbs up, so I think we're
Okay,
okay.
thumbs up on Facebook. Okay.
And it's just now 8:31, so probably okay to get started.
Okay. All right.
I'm looking. So should I put people's names?
So.
Okay. Yeah, I think we're all right.
All right. All right. Looks like everything's connected
Just
on
kinda
social
seeing.
media. Looks like we've got everybody attached. So again, this is going to be a question and answer session based on questions people have been putting on social media. When you put questions, please just ask questions. When we get 3 paragraphs with the question hidden in there, it's kind of hard to find those and answer them. So if you are putting questions out there on social media, just try to make them brief and to the point. We did get some clinical vignettes, and it makes it kind of hard. And once we have everything ready, we will go ahead and start.
I think we're all set.
Okay, great.
All right.
So anyway, just a summary. This is a question and answer session. Rebecca will be asking the questions in the background. That'll be the voice, the young lady that'll be asking the questions, and then I'll be answering them to the best of my ability. This is not medical advice. This is my opinion as a physician, clinical researcher, functional medicine practitioner, integrative, holistic, board certified physician, et cetera, but this is not to be construed as the opinion of any international science and literature as a practicing clinician with about 20 years of clinical experience. So I just got to put that caveat out there. So
Also, just really quickly, can you go over that it's on Facebook, YouTube, Instagram? Facebook and YouTube are the same, actually.
okay.
And people have an Instagram, they can hop over there and vice versa.
Gotcha, guys. So this right now is on Facebook, Instagram, and
YouTube Live.
YouTube. So if one of these stops wherever you're at, you can always just switch to the other media. They'll be reposted later as a recording, but if for some reason it cuts out, just switch either to YouTube or Instagram or Facebook. So
Okay, let's go. Okay, Little League sports are starting back next week. What are your thoughts on the safety of this?
So we've been getting a lot of questions in regards to children's activities in the summertime. So I think, whether it's Little League sports, whether it's the swimming pool, whether it's camps, I think the underlying idea that kids are at a very, very low risk. This is less dangerous in kids than a typical flu. So I guess the question would be, would you not send your kids to Little League if flu was going around? And that's my basic answer to that. The kids are the young, healthy ones. They're the low-risk individuals. Camps, same kind of thing. The high-risk people, it appears that highest risk issues are going to be vitamin D deficiency, obesity, diabetes are like some of the major issues, as well as high blood pressure. Kids tend not to have these issues. So in general, little league sports are actually okay. You want your kids to be active. This thing is killed outside. Being outside is probably the safest place to be. The UV radiation from the sun kills it. The heat kills it. Hot objects over 133 degrees, which is any metal object in the sun, dies. So I think outdoors are pretty safe.
So you kind of covered the other question was pool openings and are they safe? The actual people know the water is safe, but how do you social distance in the water?
I mean, I think the social distancing is a pragmatic perspective as a father who has a 9-year-old social extrovert son who has no strangers. How do you tell kids to social distance? How do you tell them to wear masks? That's outside my expertise as a physician and relies on parents and parenting issues. I just don't know how that would work with my kids. Chlorine, sodium hypochlorite, which is in chlorine pools, is one of the major killers of this virus. So pools are a pretty safe place. And social distancing, the major utility of social distancing is actually indoors, where you don't have fluid air movement. We don't have laminar flow of air, so you literally have aerosolized particles sitting in the air. That does not happen outside, where you have even a basic breeze is moving large volumes of air. So again, pools are fairly safe, and you have to realize there's also a lot more humidity in the air. Things are going to drop out of the air quicker in a pool environment because of the increased humidity. And as the summertime comes along and the humidity goes up, you're also going to have a lot more the particles in there falling out quicker because they're weighted down with water in the air. So overall, pretty safe place to be. Basically, if you're outdoors, that's pretty safe. It's really interesting. There's this article that was probably posted on social media, and it was interesting. Ford actually is taking police cars and actually putting a chip in it that when the police officers stop the car and close it down, the car cuts back on, turns the heat on, turn up to 133 degrees for 15 minutes and cuts off. And literally 95 to 99% of all the virus is killed in the car during that 15-minute time frame. So in the summertime, my car is probably closer to 150 to 160. Point being, heat kills this thing fairly effectively. So
I have a question about COVID-19 and autoimmune disease. Has there been much research on autoimmune disease and what effect COVID has on people with those diseases, especially with regard to triggering an autoimmune flare-up?
Yeah, autoimmune disease is about 1 in 12 Americans have an autoimmune disease. So this is a very, very common question. Autoimmune diseases as a whole, if you put them together, are the second or third most common cause of chronic disease in our country, which is a pretty profound statistic to think about. The thing about autoimmune diseases is they are not ubiquitous. They're different. If you're asthmatic, which is a Th2 dominant autoimmune disease, that's different than lupus, which is a Th1 dominant autoimmune disease. It also depends on whether you're actively inflamed or not. What we understand from COVID-19 is a lot of the morbidity and mortality is from the second phase of the viral infection, where people's immune system, mainly their innate immune system, actually goes out of whack, and they create lots of cytokines, which are mainly a part of your innate immune system, not your adaptive immune system, which is the Th1, Th2 part. We do know that inflammation increases the issues, morbidity risks with this, particularly things that revolve around metabolic syndrome. So that's probably a bigger umbrella. That's your high blood pressure, diabetes, high triglycerides, elevated sugars. There's some interesting data coming out with newly diagnosed diabetic increased risk for this disease. Yes, autoimmune diseases are inflammatory diseases. Yes, I would assume that you're going to be at a high risk because you have an autoimmune disease, but we just haven't seen anything published on that yet. It's mainly inflammatory diseases that revolve around metabolic syndrome type things, including sleep apnea, gout, kidney stones. These are all kind of fall into the metabolic disease realm. Most of the literature is with obesity, diabetes, some stuff with sleep apnea, hypertension. Again, if you're not actively autoimmune, I would do all the I would not say you had an increased risk more than someone else with a different chronic disease.
A quick related question just came in. Would prediabetes be treated the same with regards to COVID as diabetes?
Um, pre-diabetes is just diabetes before someone else decides to call it diabetes. So if your sugar is over 5.5, you have an increased risk of endothelial dysfunction. You already have inflammatory markers. So we don't have pre-diabetic literature on this because no one's looking at pre-diabetes in general in our country, even though 35% of our country is pre-diabetic. However, you do see the similar inflammatory markers with pre-diabetes that you see with full-blown diabetes. It's just an earlier state. It takes about anywhere from 8 to 12 to 15 years from going from insulin resistance to full-blown diabetic, and it's just a continuum of increased inflammation, increased insulin resistance. It's interesting. The hsCRP, which is something we see in diabetics that's elevated, is a correlate to the interleukins 1 and 6, which are things we see elevated in severe COVID-19. Those are markers we see elevated in people with metabolic diseases, particularly diabetes. So the risk is there. It's just not going to be as great. The literature we're seeing about diabetics is that the higher the sugars are, the more controlled it is, the higher risk you are. So if you're pre-diabetic, now's a great time to be proactive, to cut out carbs and grains under control, to make sure your vitamin D level is appropriate. If you're pre-diabetic, I'm 99% sure your vitamin D level is low. Your C is kind of borderline. You probably have some B vitamin deficiencies. So I'd focus on all these things to help lower your risk for inflammation. That there is literature that doing these things may limit or decrease the disease severity of this entity. I will throw on a side note here. I actually learned an interesting fact from talking with a local restaurateur who's Indian, who has like a ton of friends in India that are physicians. And I've read some things about firsthand that in India, if you pay attention to some of the literature, India, yeah, it's a huge country, over 1 billion people, but they're not having a massive uptake in mortality to date that we'd expect for a country as big as like we did in China. I mean, literally right by China. Interesting enough, in India, they when you get admitted to the hospital, they give people curcumin or turmeric tea, ginger tea, and EGCG or green tea throughout the hospital stays as anti-inflammatories. That really is intriguing to me because the Institute for Functional Medicine put out this practitioner guide 6 weeks ago looking at modulators, inflammation, and the inflammatory stages, and all these substances were actually anti-inflammatory agents they recommended. So, inflammation is a big player in this, and there's many things you can do to diminish inflammation. I actually did a blog post on inflammation on our website that actually talks more in depth about lowering inflammation. So if you want more, it has some pretty good recommendations there for you.
Okay, and a follow-up to the autoimmune discussion, would you recommend that people with autoimmune conditions wear an N95 mask when they go out? And then maybe comment on where you've heard people finding them.
Okay.
And if not, do you recommend the 3-layer cloth masks the WHO recommends?
I mean, if you have an autoimmune issue, I mean, it's an inflammatory condition per se. It's an immune modulatory condition. I think the best thing to do is wear it. I mean, you want to minimize your, you want to do all the things we've talked about in the past on multiple other sites and as well on the blogs, etc. But you do want to minimize your risk. You want to decrease it. And N95 is better. It removes 95% of the particulates, which is huge. If you can't get a hold of it. Personally, actually, I had a patient. She's a great, awesome patient. She might be watching right now. Who basically, I think she'll probably, if she's watching, she'll probably know it. Correct me if I'm wrong. But I think she said she went to Home Depot or Lowe's and she got N95 masks for myself and my staff maybe 4 weeks ago, and they were available. So I mean, you're going to pay a little more now than you would have paid months ago, but they're out there. If you can't find them at a local Home Depot, Lowe's, a small local hardware store, then you can use the 3-layer masks. The best thing. The idea behind those is you can actually make your own mask from the WHO about 2 weeks ago, which is just old information being recycled all over again. We know that anything in front of your face is going to slow air velocity. It's going to decrease water droplet spread. One thing that people where this stuff is aerosolized everywhere with nebulizers, you are much more likely to have severe disease than if you get exposed to a random particle in the air somewhere walking through a building. So the face masks diminish that viral load exposure that we think probably plays into their protective effect. So, something is better than nothing. N95 is best. I have a few people using N100 masks, but they're kind of hard to. You might feel claustrophobic in those.
I hear what you're saying about mortality for under age 25 being less than the flu, but is this more easily transmitted than the flu? Would we expect to see more deaths than the typical flu just due to high numbers of cases? Thinking about the fall.
Yeah, the thing is, when you talk about this in the flu, the typical flu, only about 25% kind of been exposed. Only about 25% of the people. The difference with this is that it's novel. No one has immunity. So if you need 60 to 70% of people to get this, automatically, say 75 for number's sake, that's 3 times more people that might get this. So automatically, if this mortality was the exact same as the flu, you'd still expect 3 times more people to die from it simply because it's novel. It really depends on how many people have already been exposed. I mean, we have no idea. New York City, 25% plus have already been exposed as of 4 weeks ago. So they might hit herd immunity by the end of the summer. Other places, some areas in California, 5% from some testing. There was a homeless place in Boston that 50% of the people they tested at this homeless center were positive. The reality is, for our country, we just don't know how many people already have that. And that's the big question mark. If the more people that get this during the summertime, the less likely we'll get an uptick. So, which would be one reason that we want our kids playing, going to camps, and going out there. We want the people that are the low risk people to get this, so that in the fall they can become the roadblocks for rapid spread for this. We want this, when it comes back in the fall, to be spread over the whole winter season, not to be crammed into a short period of time. And I would assume, to be honest with you, that typically you see influenza outbreaks in the local environment usually is about a 6-week time frame. Yes, flu seasons from November to April, May, depending on where you're at in the country. But typically in the local environment, it's about 6 weeks when it goes crazy, and that tends to correspond with naders and vitamin D levels, with cold air, with the humidity, with how the lack of access to outside. So a lot of different factors play into that. So, but I'd expect this to be similar to other respiratory tract infections, where it should hopefully be spread throughout the winter. It won't be all crammed into one short time frame. This thing kind of popped up during a typical to have the intense numbers, even though we know that was actually here in the United States in late December, maybe even earlier. So anyway, that's a long-winded answer, I know, to that question. But yeah, it's going to probably pick back up when kids go back to school, because kids will be back in school.
Someone asked a question about what is the best test for COVID, and I just want to mention, or you can mention, the last video right before this one is basically a whole video covering that. So just in case anybody hasn't seen the last one, it's like on the reliability of COVID-19 testing or something. It's titled something like that. It's literally the last video before this one. So on Instagram, you'll see just the title. On Facebook, if you go into our videos, it will be the one right before this.
So as far as the question today about the most reliable test, depends on if you're acutely in disease versus if you think you had it 4 to 6 weeks ago. If you think you're sick now, the best test is going to be the viral PCR test, which is either nasal swab, or LabCorp is doing an oral swab. They actually ran out of the nasal swabs and switched over a couple of weeks ago. But it depends on when you're sick. The test is most accurate in the first 3 days of illness, greater than 90% accuracy. At day 6 to 7, accuracy drops down to 80%. And if it's 10 plus days, the viral PCR swab drops, its sensitivity actually drops to less than 60%. So if acutely, that's what you want. As far as if you think you were sick, then that's just where you're doing IgG doing the serum testing, which I talk in depth about that in the video and my opinions about that and some experiments I did actually in my own clinic with patients. We've been seeing patients with this and testing. We've been testing for this since March, and I've had a fair amount of experience testing people, tracking their families, retesting with different tests. I actually talk about that in detail in that video. So,
does O positive blood have anything to do with COVID?
This is something that popped up. It came out. There's a lot of things that are kind of wash and repeat things in the media where it pops up. It goes, the mask thing, right? They're bad, they're good, they're bad, they're good. This is something that popped up maybe 2 months ago. I think the big thing is people do have different types of antigens on their blood. They can be related to some, in small degrees, to different inflammatory diseases. But in general, for this, it's a small blip, not enough to make a big deal about it. I'd be more concerned about your vitamin D status, about your nutrient status. If your thiamine, pyridoxine, your B vitamin status is low, those are bigger markers than if you're a type O or AB positive or whatnot. So, and plus, you can't change your blood type, but you can vitamin D status, for example. There was a great article I did talk about that came out with the Lancet, and Lancet did it's the best review article you're going to get. Minus doing an actual randomized trial on this, which is no one's going to do a $25 million trial on a $2 supplement. But it did review all the European literature, and they showed direct correlations with vitamin D levels and severity of disease, risk for ICU admission, as well as risk for death in the ICU based on your vitamin D status. And
that one is a picture of a beach, if you are looking for it in our feed.
Yeah. So.
Okay. I'm worried about a loved one who is a smoker. Have you had anyone who is a smoker recover from COVID-19?
So I'm saying they are smokers, so I assume that means they're currently a smoker. Yes, I have. I've had previous smokers recover as well. In my clinic, to be honest with you, I've had a lot of patients have COVID-19. So I've had experiences like that. One of my patients, actually, her son was admitted in the ICU for almost 2 months, and everybody in her family got sick. He survived, so I have stories like that. I personally don't have any story of anybody dying yet in my clinic, which I know there are people that are dying from it, so I don't want to minimize that. If you're smoking, it's a risk factor. It causes lung inflammation. I mean, there's literature now out there that if you're in a city with high, you have a risk for increased severity of COVID-19. If you are exposed to more combusted smoke particles, you have an increased risk for severity of COVID-19. And I've either put those out there in social media, or those are going to be put out over the next couple of weeks. I'm not sure where we're at in the cycle with that. It's a concern. There are some things you can do, however, like vitamin C. If someone smokes, you need 10 times more vitamin C consumption to mitigate the inflammatory response of smoking than a non-smoker. NAC, N-acetylcysteine, was something back in the 1980s, actually, that physicians were using to treat COPD before some of the newer fancy drugs came out, and that's a supplement you can get. Vitamin D status, pretty much all my smokers are vitamin D deficient, get those levels up, but ultimately, they need to quit smoking. That's the biggest thing. Okay.
Could you Okay, I just messed up everything.
Technical difficulties with the iPad with the questions on them. So,
could you talk a little bit about the WHO statements about asymptomatic spread and the fact that their position keeps changing?
Yeah, that's more of a political question, I guess. Whenever we talk about WHO statements, CDC statements, you have to realize these are governmental organizations. They have political influences. There's a lot going on. It's not simply the best and brightest minds getting together and making a statement. There's a whole filtering process, and it's by committee is just not the best kind of mess. And making a recommendation that applies to the CDC, that applies to over 7 million people from thousands of different ethnic groups that have thousands of different languages from different ages. It's like, how do you make a recommendation like that to apply to everybody? I mean, I don't know if I could. pretty profound. I make recommendations to individuals. My field of expertise is talking to people, evaluating their risk factors, and then giving them recommendations, not looking at a map of the world and saying everybody in the universe should do this. So that's part of the reason why you see inconsistency. Also because of the political bent of some of these things, you'll see a recommendation come out, and then things change really quickly. The hydroxychloroquine is a great example of that. I did put out something on social media. Lancet just retracted their, and this is not political. This is just me stating what Lancet said, so don't take this the wrong way. Social media world, please. But literally, Lancet just retracted that article that said that hydroxychloroquine didn't work because the data collection, the company collecting the data, when questioned, because someone wanted to look at the data, because typically in published studies, I should be able to request the data and look at, they could not reproduce the data. So the Lancet pulled that back because they're like, wait a second, we published an article that now people are questioning the data and we can't produce it. So this stuff happens. 3 months ago. So people and that. So someone will say, well, I picked a viral particle up, a speck of dust in the air, so therefore the mask doesn't work. And it's like, well, a speck of virus in the air doesn't mean the mask doesn't work. It just means there's a speck of virus in there. And that's where a lot of things are being conflated. A mask is not 100% perfect, but it works really, really daggone good. And if you minimize the viral exposure, you have less risk. And that's where you have these things come out. The media questions that someone else has a report, they get retracted, new literature comes out, puts back out. And that's what just is hard for the average person to know how to interpret this, because it's confusing and it's frustrating on my end, because we get the same questions over and over again. It's like masks. Surgeons wear masks when they do surgery. They've been doing that for decades. We've used masks for infectious disease prevention for decades, if not almost close to a century maybe. So they work. We use them for a reason. I don't understand why it's such a difficult question, and why major organizations that are supposed to give us pretty reliable, dependable recommendations can't stick with it. But I think that's where medicine by committee is not probably what most people want. So again, one of the mantras I've said is find reliable sources, good sources of information, stick with those. And if you see something that doesn't quite make sense, don't necessarily let it rock your world, because it will change in a week. The idea of truth is a philosophical perspective. Facts are interpreted, and people are reinterpreting facts all the time. Truth is different. It's consistent. It doesn't change. And that's where truth and masks work. They work. It's just how do you interpret the facts behind that. I'm sorry, that was a little long-winded.
Inflammatory syndrome in children, MIS-C, and I'm seeing a lot of people who are scared and using that as an excuse not to start school back up.
Okay, I think school backup and multiple system inflammatory disease are two different questions. I'll talk about the inflammatory disease first. I looked at this the other day, and as of mid-May, cases of this in the country. Okay, to put that in perspective, as of today, there's over 2 million cases of COVID-19 in the country. So that's a pretty daggone low risk for getting that. 102 out of 2 million. Is it terrible? Absolutely. It's going to be devastating. The risk for it's pretty low. And there's things called Kawasaki's disease, which is something I learned about in medical school, which is another. This thing seems very similar to Kawasaki's disease, which Kawasaki's we assume is virally induced, this post-viral inflammatory process where kids get aneurysms and red eyes and tongues, and it's really a pretty nasty thing. There are other post-infectious inflammatory conditions. Guillain-Barré is one where you get demyelination of your nerves. It happens about 1 in a million with flu shots, for example. These things are out there, they're super rare, but we shouldn't necessarily make school reentry policies based on the exception rather than the rule. Ultimately, kids are low risk. Every year when kids go back to school, what happens? About 3 to 4 weeks in, you can predict it. I start seeing lots of people in my office. Kids are getting sick. Everybody's getting runny noses and coughs and sinus issues. That happens every year. They go back home. for Christmas. They come back, happens, 2 or 3 weeks after they come back from Christmas. This happens all the time, and we should kind of expect that. My wife did the math on the multiple systemic inflammatory disease, and it came out at 0.005% of the total cases of that in the country end up getting this disease. So pretty low risk.
Are there any updates on the actual mortality rate? I hear so many doctors agree that this is not as deadly as we thought, so why is the government still acting like this is a serious threat?
That's another political kind of sort of question, I think. The first part is the update. I wish I could give you an update on America, but America is basically 50 countries that are kind of stuck together. From England, there was an update a couple weeks ago, and I think we're going to put that article out there if it's not already out there.
At the end of
I
have to go find it.
We have to go find it. It'll be attached here somewhere. Just look for it.
Comments.
The comment, there we go. But in England, it's a 0.5% mortality, and that's the overall mortality. So if you look at, again, less than 25 to 30, it's less than the flu. If you're over 85, it's like a 15% mortality, but it's also 85% surviving is another way to look at it. We haven't really seen that number budge a whole lot. We're learning more about nuances, about obesity versus diabetes for the risk. And I think that's where we're refining our numbers right now. The 0.5%, it might go down a little bit, but it's not going to be like the 12.4% from the China to the Italy numbers were at one point in time 14%, or the 5.4% from Wuhan, or it's not going to be anything like that kind of big a change. It might be 0.5 to 0.4 or whatever. It's still worse than the regular flu. But what we're now defining now is like certain populations, like if you're obese, if you have diabetes, if your sugars are high. We're actually redefining certain populations like vitamin D status. There's a lot of great literature coming out of Europe with vitamin D status and the risk. I mean, for example, I mentioned this in social media a couple of weeks ago, that if you're in Indonesia and you're in the ICU, so kind of sick already, and your vitamin D status less than 15, which is really low, that you have a 10.14 fold increased risk for dying. So we're redefining the risk numbers more on those lines. Smoking, air pollution. If you live in an area that has a lot of air pollution, you have a fourfold increased risk for complications, for example, with COVID-19. So maybe that explains the New York phenomena and the Northern Italy phenomena and the Wuhan phenomena and the London phenomena. These are all areas that have a lot of. Those are the kind of things we're kind of fine-tuning right now, understanding of what individual factors in the population increase your risk more. Not so much the overall, because at this stage, the 0.5%, what does that mean? If you're 12, it means nothing because it's like super, super low. And if you're an obese, diabetic male who is over 80, so that's where we're kind of fine-tuning it right now.
Should the number of COVID cases be the only determination for opening back up, or should it be based more on hospitalizations and deaths as compared to overall cases?
Yeah, that's a great point. It's a great question. We don't really know how many people have this disease yet in Virginia or in the United States, because we're not actually doing, at least in Virginia, statewide or nationwide surveillance stuff to see how many people have this. So we don't actually, we're still guessing 10 times more people have it than we think. Our problem with the testing is we're only testing people who request, at least in Virginia where I'm at, we're only testing people who request it or hospitalized. We're not actually testing the general population. So we're testing a subset of the population that self-selects, which makes our guesstimates on our surveillance data skewed. So we don't really know how many people in our country have it. That'd be great to know, because then we could say, hey, maybe it's 20 times more than what we think versus 10. There's a ton of asymptomatic spreaders. Maybe it's closer to 80%, which is one article suggested, versus 50% from the Icelandic data. One thing suggested as low as 5%. So if something ranges between 80 and 5%, that just tells me we have no idea. So that's where it's hard. The better data is who's getting hospitalized, because those are your sick people, and who's dying. Those are the most important numbers. And I looked at the numbers this past week from the Worldometer in both Hopkins site, and you see them overall in our country. In my state, in most states, you see them going down. You don't see them going up. So people getting infections going up. Sure, more people are going to get this, but I think we're just seeing a phenomenon of more younger people going out. With a lot of social unrest right now, it's mainly younger people. It's not, typically grandparents that are diabetic that, have multiple health issues, even though there are some out there that, are going out and things are happening to them. But it's mostly young people. So, yeah, I expect to see the numbers go up just like we did after spring break when I was in Miami, or after Mardi Gras in New Orleans, right? We saw things pick up. So we're going to see that. It's to be expected. We've been talking about that. Things will go back up once people go to school. The bigger question is, are the numbers of deaths going up in more proportion than we expect for the numbers to go up? And if it is, that's a different story. But, if the numbers bump up 10% more people get it, then I expect to see 10% more deaths. And that's actually not what we're seeing right now.
Can you speak to just the idea that, like, this is
mentioned, this is not going anywhere, and that's something that people have to realize. Have to get this is not going anywhere until until we get to herd immunity. Whether herd immunity comes from vaccination, where we all get vaccinated, or of the population is vaccinated. So the question is, what's a good public policy that will keep our society together, that'll keep our kids educated, that'll keep most of us employed, for the next 2 to 3 years. And that's kind of what we need to keep our mind on. If a vaccine pops up in September, which would be the fastest vaccine production in the history of the world that I've ever heard of, it still takes 6 months to get deployed. So we're still looking at getting deployed late winter. So what makes sense is to do what they did in Sweden and other countries. Even some states in the United States have done this, where they just didn't close, and they told the sicker people to. I'm having a kid sneak in the thing right now. I need to go, Cleo.
Okay. Fear a second wave and shut everything back down if our odds are similar to a seasonal flu. Like the mortality rate is similar.
That's kind of a self-answering question. We don't do this for the flu typically, so it's interesting. The Hong Kong flu of 1968, the population of our country at that point in time was about 200 million, and 100,000 people died to about 100,000 people dying from this. So we didn't shut down any major. It just kind of went through. So shutting everything down again, when we did it the first time, and we didn't. And the question is how much of what's going on in our country right now, from a social unrest, from all these other things going on, is or secondary epiphenomena from having the whole country quarantined and shut down. Can we go through another round of that as a country and society? Maybe that's a better way to ask the question. Ultimately, that's a political question up to our leaders to decide.
Could you touch on herd immunity and any benefits from getting COVID naturally versus through a vaccine should one become available? And then there's a couple more parts to that question, but I'll stop there.
Natural immunity is always better than vaccination. The regular flu vaccine, at best is 70% effective. Sometimes it's effective. There's some years that literally we do it and it's like, oops, we picked the wrong virus, and literally it's not really hardly effective at all. So we're assuming that this virus is not going to mutate as much by the time the vaccine comes out. But the natural way is always better than the vaccination. But vaccines work, and vaccines can get herd immunity. It's kind of how we get polio. It's how we eradicated Hep B in our country, basically. Pediatric meningitis is mostly non-existent due to the Hib and Prevnar vaccines. So they work. They work. So
Are the risks of this virus great enough that we need to live in a bubble until a vaccine is made, if ever?
That's a interesting question. I think the answer is no. I think I've kind of answered that already. Do we check the safety of any FDA-approved drugs? And the answer is no. That's what phase 4 trials are. So, phase 1 trial is a safety trial. And you pick, a small group of people, you expose them to the drug, and you see if it's safe. Your phase 2 is your dosing trials. How much do you need to get a certain physiological effect? And your phase 3 trials, which is mostly what I do in my research company, where you take the drug at the dose you think, and you say, hey, do we actually get enough study population data where it goes out and gets deployed? We've had vaccines before, like the Lyme vaccine or the swine flu vaccine that didn't work out that great. So you never know how safe any vaccine is until it's actually deployed. You never know how safe any drug is until it's deployed. That's one of the reasons why I personally tend not to be the first person to jump on board, or the last person, unless the intervention is so disease altering that you have to jump on it as soon as it comes out. And there are things like that that do come out. Ultimately, this vaccine, we just got to see what comes out. We don't know yet. There's over 100 different trials going on right now. And so we don't know which ones are actually going to make it. And then we won't know until they actually make it through approval, and have to look at the literature and the data and say, hey, how effective is this based on data? Is it only antibody response? Because a lot of vaccines are solely antibody response studies, not actual clinical studies. And then, what the safety information is, Great question. We'll have to figure that one out.
I'm not sure when we discussed autoimmune disease if we fully explored your thoughts on whether it could cause a flare. Did you already cover that?
You didn't ask that question.
Okay. So as far as
yeah, the question, the underlying question is, the specific question is, can infection with COVID-19 disease? By definition, you have to have one of 4 things to have an autoimmune disease. And this is, according to Dr. Yehuda Schoenfeld, who's one of the top immunologists in the world. He's at the University of Tel Aviv. And one of the 4 things you have to have is an infection of some sort. Our understanding of autoimmune diseases is actually there's an infectious process, whether that's a low-grade GI tract infection, SIBO, SIFO, whether it's an Epstein-Barr virus infection. There's data with Hashimoto's, as well as multiple sclerosis and certain cancers, actually, Burkitt's lymphoma, certain leukemias being triggered by a low-grade Epstein-Barr virus infections. So for an autoimmune disease, you have to have an infection of some sort to kind of trigger your immune. So could COVID-19 cause looks that's true for flu. That's true for any infection. I have some of my patients with autoimmune issues get the seasonal throat, and they should be better in a week, and their rheumatoid flares. Actually, great example. There is the model there for infections causing flares of autoimmune diseases. We don't know specifically for COVID-19 any particular autoimmune disease as of yet. We do have this inflammatory syndrome, but I would say any infectious disease could cause a flare in your underlying autoimmune process based on what we know about them.
Could you share just some of what is coming up in the next couple weeks on our social channels?
Sure. So we're working on just some general information to help everybody kind of get through stuff with things you can do revolving on certain nutrients, supplements, putting some little information about resilience. It's an idea I'm kind of playing. How can you build resilience, not just to COVID-19 and not to just stress and social unrest, but just life in general. These are some ideas I've been kind of mulling the last 4 to 5 months, and it seems like resilience in my mind is a big issue right now. So we're going to start throwing out some basic information about that. We may actually turn it into a blog series or some kind of podcast or something. It's just, if we have time for that. But we are working out those things and putting that out there in social media. We have rebooted a little bit with social media, and so we'll be changing things a little bit and just kind of putting some general information for health improvement, resilience building, and then as things pop up with new things with COVID-19. One thing I'd like to put something out there is some interesting literature I'm looking at, mainly from the UK and Europe, on certain actually modifiable, I think the key is modifiable factors that may be the major cause for the ethnic disparities we're seeing in different ethnic groups in Europe and the UK with COVID-19. So I think that's kind of exciting because some of those factors, certain gene factors, but as well as some things like vitamin D status, you can almost track the disparity between males and females in the severity of COVID-19 with the vitamin D status, as well as some of the UK data. And it's mainly in London. London's a very diverse city, and they have a ton of different ethnic groups there, and the disparities they're seeing correlate really, correlation is not causation, but with vitamin D status. So this is the kind of stuff we're going to be throwing out there over the next several weeks and month, and as things go forward.
I liked the thing that you said the other day about that you like, in order to like fight for what you believe in, you have to like, in order to, I liked
sure.
that.
The things you believe in. Wherever you're fighting. There's a lot of stuff going right now in the world, whether it's just keeping your family safe. That's a big issue with a lot of people right now, just personal and family safety. If you don't have your health, you can't really fulfill your dreams. You can't stand up for anything worth standing up for. You can't fight injustice if you literally don't have the strength to get out of bed in the morning. Or if you're so scared to go outside because you think you might get sick from COVID-19. Your health is huge. And so, if nothing, my part, I feel like I can play in this, as a 47-year-old father of 3 kids, what I have to offer is my expertise in building resiliency. All our kids we adopted from pretty bad situations. Some came to us with asthma and bad lung issues, different exposures to chemicals that kids aren't supposed to be exposed to, different traumas, and they've all developed. One of them has had an antibiotic since we've had them.
Since we've had them.
Yeah, since we've had them, one has had an antibiotic, which is pretty profound from a kind of what, you can't stand up for what you believe in if you don't have your health, if you don't have the energy, if you don't have the mental acuity to think things through clearly. If you're in fight or flight mode and so stressed, you can't. Like us, hit the little bell or whatever things that people on social media tell you to hit, because that's how this stuff gets spread around. We're a small get up. We don't have a name, but I feel like we have useful information. I've heard over the multiple times from patients in the office, this is helping them kind of get through stuff, helping them stay, giving them usable information. So if you feel that way, please share it, because that's how this information gets out there.